Number 8. Auto-brewery syndrome glucose challenge. You register a blood alcohol level, but you have not had a drink. That is the trap. The number looks familiar, so everyone looks for alcohol first. In reported cases, people have faced DUI accusations, job problems, and years of being told the story cannot be true. In 2013, Barbara Cordell and Justin McCarthy described a 61-year-old Texas man from Texas whose blood alcohol rose after a carbohydrate challenge despite no alcohol intake. The mechanism was not a bottle. It was fermentation in the gut, linked in reports to Saccharomyces cerevisiae, Candida albicans, Candida glabrata, and less often bacteria such as Klebsiella pneumoniae, often after a microbiome shift. A 2019 BMJ open gastroenterology case began after antibiotics for a thumb injury. The test is controlled. You fast. Clinicians measure baseline blood alcohol. You ingest glucose. Then they check blood or breath alcohol for several hours under observation. Before anyone uses fluconazole, cuts carbohydrates, adds probiotics, or changes antibiotics, they must rule out hidden drinking, lab error, and outside ethanol exposure. Without that proof, a gut-making alcohol can look exactly like a patient who is lying. Number 7. Fatal posterior circulation stroke with persistent hiccups. In March 2007, neurologists at National Taiwan University Hospital reported a 49-year-old man with persistent hiccups, repeated vomiting, vertigo, unsteady gait, and numbness on one side of the face and body. MRI showed an acute infarction in the left lateral medulla, a brainstem area supplied by the posterior circulation. This is lateral medullary syndrome, described by Adolf Wallenberg in 1895, often caused by blockage of the vertebral artery or posterior inferior cerebellar artery, known as pica. The medulla oblongata contains the nucleus tractus solitarius and nucleus ambiguus, nuclei coordinating swallowing, gag reflexes, vomiting, autonomic control, and respiratory-related rhythms. That is why this stroke can look like gastroenteritis. Patients may leave the ED with nausea and hiccups, then return hours later with worsening brainstem deficits. Posterior circulation strokes cause about 20 to 25% of ischemic strokes. Brainstem edema can peak within 24 to 72 hours. If the infarct extends into respiratory centers, ventilation may be needed during the same admission. If hiccups last more than 48 hours with vertigo, facial numbness, or trouble walking, you do not wait. Your imaging needs to include the posterior circulation. Number 6. Young adult fatal ruptured saccular brain aneurysm. At a branch point in the circle of Willis, arterial pressure finds its thinnest wall. A saccular aneurysm forms there, a small outpouching in the artery wall, and these make up about 90% of intracranial aneurysms. Most sit in the anterior circulation, often at the anterior communicating artery or the middle cerebral artery bifurcation. If it ruptures, blood floods the subarachnoid space around the brain. The first sign can be a thunderclap headache, maximum pain within seconds. Then vomiting, neck stiffness, seizure, loss of consciousness, or coma can follow. The condition is uncommon, about 6 to 9 cases per 100,000 person years worldwide. Still, roughly 10% to 15% die before reaching a hospital, and overall case fatality is often 30% to 40%. Diagnosis runs CT to lumbar puncture to angiography in hours. Clipping or coiling must follow before the vessel tears again. If you feel the worst headache of your life hit all at once, you do not wait. Youth does not protect you from a ruptured artery. Number 5. Adult urgent care death from acute epiglottitis. In January 1988, 37-year-old Len O'Connor, a Chicago radio and television reporter, went to a suburban urgent care center with a severe sore throat and trouble breathing. He had acute epiglottitis. This is not a routine throat infection. The infection swells the epiglottis, the flap of tissue at the base of the tongue that helps cover the windpipe during swallowing, along with nearby tissue above the larynx. That swollen tissue sits directly over the airway. As it expands, the air passage narrows within hours. The voice turns muffled. Breathing becomes audibly labored, a warning sound called stridor. Swallowing fails because the same swollen tissue crowds the route for air and food. If you hear that harsh breathing sound in someone else, or in yourself, you do not wait for lab results. In children, Hib vaccination later made this disease far less common, but adults still get it from Hib, Streptococcus pneumoniae, Staphylococcus aureus, or Group A Streptococcus. The only priority is securing the airway before it closes completely. A breathing tube or surgical airway may be needed. Once it closes, there is no route for air and no intervention that matters. O'Connor died when a sore throat became an airway obstruction. Number 4. Sneezing-induced arterial rupture and vascular Ehlers-Danlos syndrome. This is a rare inherited connective tissue disorder where the wall of an artery can fail after an ordinary pressure spike, including a cough, vomiting, or a sneeze. The defect sits in COL3A1, the gene for the pro-alpha-1 chain of type 3 collagen, a structural protein that helps reinforce blood vessels and hollow organs. It was formerly called Ehlers-Danlos syndrome type 4, and its estimated prevalence is often cited between 1 in 50,000 and 1 in 200,000 people. The danger is not the sneeze. The danger is an arterial wall built with weakened collagen, so rupture or dissection can occur with little or no trauma. One recognized complication is a spontaneous carotid cavernous fistula, where the internal carotid artery opens into the cavernous sinus behind the eye, causing sudden eye swelling, a brew, double vision, or vision loss. Gene Reviews identifies COL3A1 molecular testing as the standard confirmation because invasive procedures can carry their own risk. Older cohort studies reported median survival around 48 years, largely from vascular rupture. In 2010, the BBEST trial reported fewer arterial events with celiprolol. Here, the warning is pressure. Next, the threat is something swallowed, hidden, and slowly moving toward disaster. Number 3. Fatal splenic rupture after wire ingestion in a detainee. In 2017, Tongche Sangsiri, a 20-year-old Thai man held at Villawood Immigration Detention Center in Sydney, reported abdominal pain after swallowing metal wire. He was taken to Liverpool Hospital where doctors identified the ingestion, then he was returned to detention. A sharp foreign body can perforate the stomach wall, and every unmonitored hour gives it more time to migrate. Just above the stomach sits the spleen, an organ that filters roughly 10 to 15% of the heart's output every minute. Injure it, and bleeding can become massive fast. When Sangsiri was sent back to hospital, the fatal injury was already declared inside his abdomen. On March 16, 2017, he died. A New South Wales coroner's court inquest later found that wire had passed through his stomach and injured his spleen, causing splenic rupture and internal bleeding. If abdominal pain follows a swallowed sharp object, you do not treat the first assessment as the whole story. The wire did not need a large wound. It needed a path, time, and an organ full of blood. Number 2. Fatal rhino-orbito-cerebral mucormycosis after tooth extraction. In May 2019, a 56-year-old man in India had an upper molar removed. Days later, his face began to swell. Then black tissue appeared inside his mouth. That color mattered. It was not bruising. It was necrosis, tissue death from a fungus invading blood vessels, blocking flow, and cutting off oxygen. The case was reported in BMJ case reports in 2020 by clinicians from King George's Medical University in Lucknow. The driver was uncontrolled type 2 diabetes mellitus. Diabetic ketoacidosis blunts neutrophil chemotaxis and phagocytosis, so immune cells cannot reach and engulf the fungus efficiently. It also lowers tissue pH into the range where mucormycosis can thrive. Within days, CT showed the fungus had crossed the ethmoid sinuses into the orbital apex and was moving toward intracranial structures. Doctors used surgical debridement and intravenous liposomal amphotericin B, the standard first-line treatment. It's still advanced. He died. A routine extraction socket was the entry point to the skull. When rhino-orbito-cerebral mucormycosis reaches this territory, reported mortality commonly runs from 25% to 62%. Number 1. Fatal Ludwig's angina from infected mandibular premolar. Ludwig's angina can start with one infected lower tooth. In a BMJ case reports case at St. Thomas's Hospital in London, a 40-year-old man developed swelling under the jaw after an infected mandibular premolar. The infection moved into the floor of the mouth, then through connected fascial spaces, submandibular, sublingual, and submental. That connection is why it can spread fast and rise on both sides at once. As the tissue swells, it pushes the tongue upward. The space behind the tongue narrows. Air has less room to pass. If you notice hard swelling under your jaw with drooling, trouble swallowing, a muffled voice, or your tongue lifting, you do not wait. This can become an airway emergency before it looks dramatic. Wilhelm Friedrich von Ludwig described it in 1836, when historical mortality was over 50%. Today, treatment starts with securing the airway, then intravenous antibiotics such as ampicillin sulbactam or clindamycin for penicillin allergy, drainage if pus is present, and removal of the infected tooth. Deaths are now usually below 10%, but only when the airway is secured before the swelling closes it.